my disclosures, but it's not going to be relevant at all to today's talk. And so this is the outline of what I'd like to talk about: a history of coronaviruses, particularly human coronaviruses, what they look like, how this new one has emerged and its features. We'll talk about it in pediatric patients, MIS-C, how we try to treat it, the collateral damage from this pandemic, and vaccines and pandemic control. And, you know, epidemiologists have told us that we're about to go through a very dark period. And I get that. We had over 80,000 cases reported in the United States yesterday. But I want to try to emphasize the positive and the hopeful, and look forward. And, you know, kids have largely been spared this in comparison to others. So I want to try to make some of this a little hopeful looking forward. So coronaviruses were first described by veterinary researchers in the 1930s as filterable agents, viruses that caused colds and other respiratory infections in chickens. And some 3 decades later, with electron micrographs, their structure was seen, and they were noted to have these projections on their surfaces that were called spikes. And they were also noted to be disrupted by solvents like ether and detergents, as you can see in those micrographs on the right. And human coronaviruses were first isolated in 1965 in a research unit in the UK, where they were investigating respiratory illnesses, and they isolated a virus from the respiratory tract of a boy with a common cold and cultivated it in human tracheal cells. And the media from these cultures would consistently produce colds in volunteers. This viral agent was also sensitive to detergents and was noted by EM to resemble those viruses that had been seen in chickens. And then other investigators found similar agents, and they were designated with names like 229E and OC43, and they acquired the name coronavirus because of the crown-like appearance on their surfaces. But these viruses mostly caused mild, self-limited colds, and they were really not of major importance or interest. But then, in 2003, a new coronavirus made the cover of Newsweek. And so, in November of the preceding year, 2002, cases of an atypical pneumonia were seen in Guangdong province in China. And the world was alerted the following March when more cases of a severe acute respiratory syndrome were reported to the WHO from places like Hong Kong, Hanoi, and Singapore. And they presented with high fever, a radiographically confirmed pneumonia, an epidemiologic link to other cases. And worldwide spread was very, very rapid, but was focal. And this map shows the number of cases that were spread around the world. There were over 8,000 probable cases in 29 countries and over 700 deaths. So it had a very high mortality. And it was initially spread within hospitals to healthcare workers. It spread to visitors and patients, family members, and then it also spread in other settings as well. And as I said, the mortality rate was very high, but in people with underlying conditions and in the elderly, they had mortality rates as high as 50%. Not much mortality, though, in young people. So a new coronavirus was identified, and it was named SARS coronavirus. And it seemed to be related to a bat virus that was probably transmitted to palm civets as an intermediate. And this virus rapidly adapted itself and through recombination and until it was able to transmit itself among humans. There was a very rapid global response to this. So WHO coordinated a rapid and effective control program involving isolation of cases, careful attention to infection control, quarantining, and travel alerts that really let people in other countries know that this was going on. And so these are the measures that were used: quarantine, where you put exposed people, in a position where they're not going to expose others; isolation, where you keep people who are diagnosed with the problem completely separated; and then contact tracing. And this really quickly stemmed the tide of this, and by mid-2004, there were no further cases of SARS. and the CDC did its part as well. But what this did do is it spurred a lot of interest in coronaviruses in general, and so there was a lot learned about their structure and function, and this schematic shows some of the important parts of the virus. So it has a positive stranded RNA genome surrounded by a protein. It's called a nucleoprotein. And then this virus has an envelope, which is a lipid bilayer, and that explains why detergents and other solvents can break it apart. Embedded within that lipid bilayer is the matrix protein, and then sticking out is that surface component, which is that structural protein of the spikes, which is involved in attachment and is also the target of neutralizing antibodies. Sensitive molecular techniques like PCR helped identify other coronaviruses. So you see the first two listed from 66 and 67, and then the SARS one in 2003, and then a couple other new human viruses were found. And if you look at multiplex panels nowadays of respiratory viral panels, you'll see these 4 coronaviruses that we routinely now check for. And then a couple years later, when MERS came out in 2012, which we'll talk about, another coronavirus was identified which caused infections in people. And so these viruses are really found wherever they're looked for, and this shows the seasonal pattern of these viruses. And then in 2012, a new one appeared that was isolated from a man who died of an overwhelming pneumonia in Saudi Arabia. And this was clearly a new coronavirus that was related to several bat coronaviruses. And then this was followed by other reports very, very quickly. And in short order, there were over 2,000 infected individuals, most of whom had really severe respiratory symptoms. And it was fatal in over 800, so a very, very high mortality rate. There was a significant secondary epidemic in Korea. They really got burned, and that is part of the reason why they were so well prepared for what we're going to talk about shortly. This shows the pattern of spread of MERS, which is the Middle Eastern Respiratory Syndrome. It's found to be present in camels and can be transmitted directly from camels to humans. But it turns out that bats may be the true reservoir that's harboring this organism. So this slide shows some of the phylogenetic relationships among the various coronaviruses, which are now divided into 4 different genuses. And 2 of them contain human coronaviruses. But you'll notice that there are coronaviruses of a variety of birds and also mammals, including pigs, mice, even whales, but particularly bats. And so what we know now is that these viruses are widespread in the animal kingdom. They evolve rapidly through mutation and recombination, and they infect a whole variety of species, and bats are particularly important, but they have an amazing capacity for jumping species barriers. So it really should have come as little surprise when yet another coronavirus was reported to be the cause of an outbreak of respiratory disease in Wuhan, China in December of 2019. And the Chinese authorities reported that the etiologic agent was a novel coronavirus as detected by EM and genomic sequencing, as we'll see. But the majority of the initial cases had been associated with visits to a seafood or live exotic animal market or by close contact with an ill family member. So the initial patients were investigated, and in this report, which was in the New England Journal in February, 3 adult patients had clinical samples obtained along with several control patients, and the samples were collected for PCR analysis, viral culture, electron microscopy, and genomic sequencing. And the initial name they gave this virus was novel 2019 coronavirus. In cell culture, there were clear cytopathic effects. And in the micrograph on the rather light micrograph on the left, you see that sort of central area where the cilia are not beating well. And on the right-hand side, in the transmission EM, you see the virus and some of its effects on the local tissue in the lung that was causing a quite severe pneumonia, which we saw on the previous slide. So the virus was then renamed SARS coronavirus and the disease that it causes was renamed COVID-19, which stands for Coronavirus Disease of 2019. By mid-January, the WHO began sending out guidance to countries on outbreak control, and by January 30th, with over 7,000 cases across almost 20 countries, they declared it a public health emergency of international concern, which is sort of their highest level of alarm. They didn't call it a pandemic until somewhat belatedly, I think, on March 11th, by which time it was on all continents, and there were local epidemics being seen in countries like Italy, Iran, South Korea, Japan, and beginning even in the US. So the transmission initially was considered likely via droplets and fomites. And you know, this explained the early emphasis that we had on things like cough etiquette, avoiding touching your face and eyes, cleaning surfaces, and hand washing. But there were some significant observations that led to the increasing belief that the virus could be airborne. And so one was the evidence of the rapid spread of the virus. But the other thing is there's something in epidemiology referred to as R0, which is the basic reproductive number. And what it is the number of people that an index case will infect in a non-immune population in the absence of any intervention. And so any number greater than 1 means the infection will continue to spread. And so the R0 value for coronavirus in the early months was in the range of 1 to 2. Now, more recent estimates have been as high as 5.7. And we'll look at what that means in a moment. The incubation period ranged from 2 to 14 days, which caused problems of its own. The median was 4 to 6 days. But in other words, it could take a potentially long time by the time you got exposed to the time you really began to display symptoms. So this slide shows from a variety of sources the reproduction numbers for the 1918 Spanish flu across the 3 waves of the epidemic at different locations in the various studies. And you see most of them range from 1 to 2.5. And we know how contagious that particular virus was. And so the coronavirus that we're currently dealing with seems to be even more contagious than that. So the early control measures involve screening measures like travel history, contacts, and symptoms. And then the infection control measures were some of the ones that I mentioned. And you know, some of these things quickly became sort of no longer useful, like asking a travel history, like have you been to Wuhan or China? Once the virus became endemic everywhere, those questions became sort of pointless. But as I mentioned, there was this concern that airborne spread was occurring. And so there was a very interesting, very influential and persuasive article that was published in Science, kind of a perspective piece that provided evidence that airborne transmission was important and that wearing masks reduced airborne transmission. And it showed how humans produce respiratory droplets ranging in size from 0.1 to 1,000 micrometers, and that there's a competition in these droplets between the size of them, inertia, gravity, evaporation, that will determine how far emitted droplets and aerosols will travel in the air. So obviously larger droplets will quickly fall to surfaces so that that can lead to surface contamination and contact transmission. But smaller droplets and aerosols, they'll evaporate faster than they settle, and so they're buoyant, and they can be transmitted by air currents, which can transport them over large distances. It's kind of like when they allowed smoking in the back of the plane, you know, and you can still smell the smoke in the front of the plane. So there's 2 major respiratory virus transmission pathways, both the contact and the airborne. And additionally, it's postulated that the smaller aerosols can penetrate deeper into the airway and cause more severe disease. So transmission of SARS coronavirus 2 can be enhanced and complicated by many factors, as we've learned. So it was recognized that infected individuals could expel virus prior to developing symptoms, which is known as pre-symptomatic transmission. And then moderate cases are infectious for a long period of time, so they can transmit. But you also learned that there was transmission from infected but completely asymptomatic individuals. We also learned about super spreader events, like choir practices and large gatherings and parties and sporting events, super spreaders. And we also learned, even though children didn't seem to have a lot of infection, that they were actually equally likely to be infected as adults. So this was an early study out of New York, and I remember one of my colleagues from back there alerted me to the findings of this study and the high mortality that was seen. And this was back in March and April when there were long lines waiting to get into the ED and ICUs were being overrun. So these are data looking at 5,700 consecutive admissions from a 12 hospital group in New York. And they looked at their data at the time of the study endpoint, which was April 4th. So of the 2,634 patients who were either discharged or had died. And if you notice where the arrows are, there were only 40 pediatric patients involved. 7 of them required ICU care, 4 were on a ventilator, but none of them died. Contrast that with what happened among the adults, where 88% of those who went on a ventilator died. So during the early stages of the outbreak, it seemed that the children were rarely affected, which could have been a result of their lower nosocomial exposure, less frequent contact with animals, or other factors as well. Many of the children were not symptomatic, and there was an emphasis in the early days toward really testing people who were sicker and more symptomatic. But later reports showed that children were equally likely to be infected, but actually had fewer symptoms, less severe disease, and a much lower case fatality rate, as we will see. And so here are some data from Clark County that show children less than 17 making up about 10% of the cases in our county. And in the United States and globally, there are far fewer cases reported in children as well. And so while children are about 22% of the US population, these data showed, and these are data up to about August, that they were about 7.3% of cases reported to the CDC. But the number and rate of cases in the US has been rising since the summer. And so we don't know the true incidence in children due to lack of widespread testing and the prioritization of testing for those with more severe illnesses. But we do know that hospitalization rates are significantly lower, and clearly children have less severe disease in general than adults. So as I said, early on, the rates were lower, but CDC began examining the changing age distribution that's been seen. And so they did that by assessing 3 indicators, looking at COVID-19-like illness-related ED visits, looking at the rates of positive PCR tests, and looking at confirmed COVID cases and getting an age breakdown. And so what they saw in these studies was a decline in the median age of cases from 46 years in May to 37 to 38 years in the summer. And what they also found was that the highest incidence rate was in persons aged 20 to 29, accounting for over 20% of all the cases. And that's being fueled by people getting out more and going to bars and things of that nature. And here are the data, again, from around the early part of the summer. And again, you see the low rates of cases in pediatrics and extremely low death rates in children. And in our own state, if you look at cases in children under 10, and the denominator in these cases is a little over 90,000, which is the number we're up to in Nevada now, you see that there's less than 10% of the cases in children and about 0.1% of the deaths. And and we're testing now along the same rates that we're seeing the cases. And here are deaths in pediatrics, and you see they're extremely low. So this is an article that was published in the Pediatric Infectious Disease Journal that reviewed a bunch of case series, all from China. And there were many of these articles to kind of choose from, so I chose a few sort of representative examples to show you. There were 11 case series in this article involving over 300 patients. Most had a contact history. The incubation period was quite long, but a mean of 7 days, which is pretty similar to others. They were able to isolate virus and respiratory secretions up to 22 days by PCR. It's not always clear if that's viable virus or not. And up to 30 days in stool, and it's certainly not clear if that represents viable virions or not as well. But a significant proportion were asymptomatic. The common symptoms that were seen were cough, fever, and pharyngitis, but a host of other symptoms were seen as well, especially among children that were not that sick. A very small number needed ICU care. This article also reported on some neonatal and maternal child series, and by and large showed that there were some neonatal complications at a higher rate than usual, and fetal distress in the pregnancies in up to 30% of the pregnancies among women who were infected with the coronavirus. This is an observational study that was done at 3 hospitals in New York. They looked at over 1,400 deliveries. They found 116 positive mothers and identified 120 neonates whom they followed. And they allowed rooming in and breastfeeding with good precautions in place. And they tested the babies at multiple time points, including at birth, at 5 to 7 days, and at 14 days. And they found that none had symptoms of COVID-19. And so they felt the conclusion was that perinatal COVID-19 was unlikely to occur with proper precautions in place. You know, AAP and others have issued guidance on what to do in terms of looking at newborns. So this was a study, another study that was done at the Mass General. They looked at children from 0 to 22 years of age who were presenting to ERs or urgent care clinics for confirmed or suspected SARS. And they were offered enrollment in this study, which was meant to look at viral loads, symptoms, and other features of infection. And so they, from the children that were enrolled, they obtained nasopharyngeal or oropharyngeal specimens as well as blood, and looked at a number of the clinical features. And these slides show the findings. And so in panel A, and it's divided up into children that had SARS coronavirus infection, those that had MIS-C, which we'll talk about briefly, and those patients that did not have coronavirus who were PCR negative. And you see they got extremely high viral loads in the infected children from the nasopharynx and the oropharynx, but none from serum. Among the MSE kids, there really was very little virus detected, but they did have antibodies. And then among the controls, there were none infected. And what this study showed in the panel B was that among the pediatric patients, even if you looked at later time points, they had a tremendous amount of virus present in their respiratory tract, even more than hospitalized adults, many of whom were on ventilators or who had severe disease. And it additionally showed that the days of symptoms, there was still a lot of virus around, and that age did not play into how much virus they found in these patients. So what is the pathophysiology of COVID-19? So it really begins with the spike protein attaching to what we now know to be the receptor protein, which is the angiotensin converting enzyme 2 receptor, which is found on the surface of alveolar and other respiratory cells, but also on some cardiovascular cells, which explains why people with underlying cardiac disease may have had a more severe disease with this virus. The virus then gets into the respiratory tract and causes airspace opacities, leading to consolidation, the ground glass opacities that were seen on radiographs and CT images with a peripheral distribution that then causes this silent progressive hypoxemia that often causes patients to need various forms of respiratory support. In some patients that have overwhelming disease, they get a cytokine storm with elevations of many of the cytokines, leading to features of ARDS and a whole host of complications. So there are many signs and symptoms of COVID. I mean, the most important early on, especially in people with serious respiratory illness, were fever, cough, and shortness of breath or problems with breathing. But many patients have a whole host of symptoms. There's a lot of variability. And many pediatric patients have GI symptoms, nausea, vomiting, diarrhea. Loss of taste or smell was something that was much more common with this particular infection than with lots of other respiratory infections that we've seen. So the clinical presentation in children really is very variable because there's an array of nonspecific symptoms that can look like a whole host of other things. The most common symptoms across the board tend to be cough and fever, but a large proportion of children are completely asymptomatic even when they're infected. And as I said, it looks a lot like other infectious diseases, so symptom-based screening to identify this can be challenging. So what do we need to do? We need to look at other things as well. So you want to look at what are the epidemiologic grounds on which we may be considering the diagnosis, as well as the clinical grounds. You can do pulse oximetry. You can do chest imaging in patients whom you think may need to come into the hospital. But the gold standard is to do the molecular testing, which basically is nasopharyngeal or oropharyngeal swabs for PCR identification of viral genome. This has excellent specificity. The problem was, and sometimes still is, that the sensitivity isn't always great because you need to obtain an excellent specimen and you need to get it processed quickly. So there can be false negatives if those things are not done correctly. There are antigen tests available. They're not as sensitive, but they can be used. And then we'll talk about serology, which looks for antibody. And there was a big problem with these serologic tests early on. We thought they might help us find our way out of the wilderness, but we ran into problems with them very early. But they do have their usefulness, and we'll talk about that in a bit. So this is a radiograph showing some of the typical findings that you see, the kind of ground glass appearance in the lungs. And then these are CT images, which are not always necessarily needed, but you can certainly see more detail with these. And so in these, you see the early disease on the left, more progressive disease in the middle with the ground glass appearance, and then very developed disease with consolidation in panel C. So this slide summarizes some of the laboratory findings and radiographic findings that we see in these patients. So a lot of white blood cell abnormalities, mostly decreased lymphocyte counts, but you can have lymphocytosis as well, but usually there's some degree of lymphopenia. There are elevated inflammatory markers of various kinds. There's transaminitis, and there's a whole host of cytokine abnormalities, including elevated IL-6, IL-10, and interferon gamma, and then the radiographic findings that we just discussed. Recently, the Infectious Diseases Society of America issued some guidelines on when to do serologic tests. And timing of the testing is very important in terms of how useful it can be, because antibodies don't begin to develop until several weeks after the symptom onset. And because of the problems that I mentioned, you don't necessarily always want to do antibody testings. But certainly among symptomatic patients with a high clinical suspicion and repeatedly negative PCR tests, you may want to do antibody testing. And pediatric patients with MIS-C, the multi-system inflammatory syndrome in children that we'll talk about shortly. But mostly the serologic tests have been used for surveillance purposes to know what is the cross-section of prevalence in a population at a given time. So let's talk about MIS-C. So back in April, there was a cluster of 8 children that presented in the UK with cardiovascular shock, fever, and hyperinflammatory syndrome. And so this syndrome was first discussed. It had a couple different names along the way. And then in early May, the CDC issued a national advisory to list the criteria for when you might look for this in someone. And so it was in children less than 21 with a serious illness leading to hospitalization, high fever, laboratory evidence of inflammation, and multi-organ system involvement, along with laboratory confirmed SARS. And this is where antibody testing can be quite useful. And so there are some reports on the data from the US published in the New England Journal. And so the slide on the left shows you the cases across the country. And you notice that the cases began to appear with a little bit of a time lag of several weeks after the peak in cases of PCR positive patients. The slide on the right shows another series that was published by the New York State Health Department of patients that presented in New York State with MIS-C. These are some of the features that were seen in these series. And you see lots of organ system involvement, lots of abnormalities in the labs in these patients. And so these are some of the criteria that are found repeatedly. In the patients in New York, they had 95 confirmed cases. There was a preponderance of cases in minority populations, and these were the presenting symptoms. So fever, chills, tachycardia, and GI symptoms were the most prominent, but rash, conjunctival injection, and mucosal changes. So a lot of these overlapped, obviously, with Kawasaki, but there's ways that you can try to sort of differentiate them to some degree. These are some of the laboratory findings in the New York State study. Again, the elevated CRP, D-dimer, troponin, and the lymphopenia. And then they also presented data on how they treated these patients. So many were treated with IVIG and steroids. Many needed vasopressor support and ICU admissions. 53% had myocarditis, and there were 2 deaths in that series. And the median length of stay was 6 days. So it was a rather serious illness that was seen in these children. So this slide looks at some of the severity of COVID illness in children. So they're less likely to develop severe illness than adults, but they're still at risk for it. And we'll look at some of the severe illness and complications, but they clearly have a much lower rate of hospitalization than adults and lower rates of mechanical ventilation, but about the same proportion of kids that get admitted wind up in the ICU. And probably a lot of that is just precaution to just be sure that we're treating these kids adequately and as aggressively as we need to make them well. Most children with severe COVID-19 illness have underlying medical conditions, but most recover completely. And a number of symptoms of underlying features have been associated with higher risk, most notably obesity and asthma and chronic lung disease, but a host of others as well. There are a number of hypotheses to try to explain the decreased severity of illness in children. Among these, that there may be less ACE2 receptors in the lungs and nasal epithelia of children, that there's differences in the innate immune responses that don't cause them to go into the cytokine storm as much as adults. There may be some cross-protection from other coronaviruses that are actually much more common in children than in adults. Exposure to vaccines, which have some immunomodulating properties, is another thought. And then the lower prevalence of the underlying conditions may be important as well. So in the management of COVID-19 in children, what do we generally do? We give supportive care, so oxygen when needed and ventilatory support as necessary, prevention and management of the complications, including aggressive monitoring, use of antimicrobials when we find co-infections, and then evaluation and management of other co-occurring conditions. There are some specific treatments that have been used, and particularly in adults, but they've been used in children as well. So we often use steroids. not only in MISC, but sometimes in severely ill pediatric patients, especially if they need to go on a ventilator. Remdesivir has also been approved for emergency authorization use in children and has been used, and I've used it many times myself. IVIG is used as well, convalescent plasma. Monoclonal antibodies and modifiers of the immune system are being looked at in clinical trials. They're not used widely in pediatrics. These are some data on use of dexamethasone and remdesivir that reported in the New England Journal recently. And you know, the improvements are not robust, but there is some rationale for using dexamethasone, particularly in patients who are on mechanical ventilation. The study with remdesivir looked at patients that were in different ranges of illness, whether they needed no respiratory support or varying levels of respiratory support. And there were some incremental improvements in length of hospitalization and duration of illness in those that were treated with remdesivir. Lastly, you know, there's been a lot of collateral damage to children. So while they have not been affected as much medically as the adult population, they've been affected in a myriad of other ways. So separation from their peer groups because of school closures and stay-at-home orders and things like that, depression and anxiety, loss of developmental milestones. The school closures have had a major impact on children. In many places, schools have been closed since March. There have been food insecurities, inadequate medical attention in all kinds of ways, coming to regular visits, but also just preventive care. This is a CDC slide that showed public school closures across the country from the end of the last school year, and you see how widespread it is. For visits to medical care, we've seen declines in outpatient pediatric visits, fewer vaccine doses administered, and we know that children are becoming at risk for many vaccine-preventable diseases. The last thing we would want to see is a measles outbreak on top of what we're seeing now. We can already anticipate that we're going to be seeing influenza. We don't need vaccine-preventable diseases on top of all that. So these are some recommendations from CDC and others about what are some of the solutions for giving immunizations and well child care. You want to try to identify and contact those who have missed well visits or vaccination visits. You want to continue developmental surveillance and recommend for early intervention when needed, prompt evaluation of newborns after discharge from the hospitals, and keeping offices and other patient areas safe for patients and families with good policies and practices. In a recent issue of Pediatrics, there was a variety of articles devoted to the pandemic. I recommend looking at it, but there was articles about pandemic intensified food insecurity, indicating that in US households, the prevalence of food insecurity has doubled to tripled from pre-pandemic levels, and that the school closings have left a lot of children without access to affordable, nutritious meals in the context of all the pandemic-related economic issues like job losses and rising food costs, et cetera. There was an article using EMR data from a Massachusetts Pediatric Care Network where researchers looked at the possible effect of social distancing on diagnoses of 12 other infectious diseases that we commonly see in primary pediatric care. And they found that all 12 were actually decreased in the calendar period comparing 2019 to 2020. And so it remains to see whether that's a real finding or whether that's being driven, is it an unforeseen consequence of not showing up for healthcare? And that is a possibility is seen by the declining rates in immunization for children. There was a cross-sectional study of 1,000 children tested at a community-based testing site in Washington, D.C. that showed the preponderance of SARS infections in minority and socioeconomically disadvantaged groups in that city. There were other analyses of maternal newborn dyads and other interesting studies that are really worth looking at that I point you to. So just toward the end here, in closing, I just wanted to show you an epi curve from the Spanish flu of 1918-1919, and a fairly recent epi curve from the US. So the Spanish flu started in the spring of 1918, very locally, but it had a first big wave in the fall of 1918, winter of 1919, and then another wave after that later in 1919. So it was 3 waves. And I argue that we are entering into what may be the 3rd wave, but probably is more likely the 2nd wave because we had that blip in the summertime. But the numbers are now rapidly rising across the country and in other countries as well. So there are, as many have said, some dark days ahead. We've been hearing about and waiting for vaccines. There are no vaccines that are licensed currently available. There's over 140 candidates in various stages of development. Many are in clinical trials. Some are in phase 3 trials. We've heard about these. And some are being used in other countries, so far not in the US. There are a variety of vaccine platforms, and some of them are really based on platforms that are entirely new that we really don't have any other examples of in current use. So certainly we have adjuvanted and non-adjuvanted protein-based vaccines and inactivated viral vaccines, but some of the others are not widely available as yet. So what are the available tools that we have for epidemic control? So again, screening and testing, and there's not enough testing, we need to have more. Isolation, quarantine are still very important. Contact tracing is difficult, but in certain settings, like in schools that have opened, it can be particularly useful to try to figure out what's going on. We've had travel restrictions, stay-at-home orders. We would like not to have to go to some of these things, and particularly not to lockdowns, but we need to try to do the things that we can easily do. So physical distancing is particularly important. Avoiding large congregate settings, especially if they're indoors. Trying to do things outdoors as much as possible. Still paying attention to cleaning surfaces that we touch a lot and washing our hands. But the wearing of masks cannot be overemphasized. And Dr. Fauci sort of mentioned this again in an interview yesterday. And I'd like to close with this very interesting article from last month's New England Journal to end on a note of some hopefulness. And this article is sort of a perspective article with an idea that they kind of equated facial masking with variolation while we wait for a vaccine. And variolation, for those of you that may not be familiar with it, preceded vaccination. And what was done in China and other places for centuries, without really understanding that smallpox was caused by a virus, people would take pus from a smallpox pustule from a person with smallpox and inject it into a person that didn't have smallpox in the hope of creating a milder form of the disease and creating immunity. This was practiced for centuries. Now, Jenner took it a step further by taking pus from a cowpox lesion and preventing smallpox. But variolation, what it attempted to do was give a small dose to allow the body to interact with the virus in a way that would prevent a serious disease. And they present in this article some epidemiologic and observational data and some animal data, and they talk about the LD50, which is the lethal dose that will kill 50% of animals given a dose of a virus. And what they argue in this perspective is that wearing masks, just like we saw in that science piece earlier, will expose us to a much lower amount of virus that perhaps our immune systems can handle in a way that doesn't do us harm. And so it's a 2.5-page article, a 5-minute read, and it's really worth your looking at. so that we can discuss the wearing of masks with people in a way that I hope will make sense for everyone. With that, I'm going to stop. I will leave this slide up of some references that I thought were useful. There was a very nice article in the Peds ID journal, some of whom were former colleagues of mine back in New York, that really reviews a lot of what we know to date in the pediatric world of coronavirus infection. There's some guidance from AAP and some other sources that I think are useful. So with that, I'll stop and thank you for your attention and take any questions that you may have.
That was wonderful. Thank you so much. Yes, we do have a few questions. Dr. Strominger, you want to go first?
Sure. You know, I was wondering what your take is on herd immunity.
You know, I mean, herd immunity is a concept that we talk about in the vaccine world, where, you know, what percentage of people do you need to have a good take to a vaccine to really, you know, prevent a lot of infection in others. And, you know, it really will depend on how infectious an agent is. Like with measles, we know we need a very, very high rate of herd immunity to prevent outbreaks, because the R0 value for measles is actually, has been estimated to be in the range of 12 to 18. And I remember having measles as a kid. I mean, when one person in the class got measles, anyone in the class that never had it before got measles. You know, it was extremely contagious. So in the context of talking about immunization, I think herd immunity is a concept that makes a lot of sense. I think to let this virus run amok in our population would be a particularly bad idea, because, you know, we saw what happened in the spring, how the numbers of cases went up and really overwhelmed us. I don't think we would want to let that happen again. If we were thinking about it in any sense, the fall and winter would be a horrible time to do it, in my opinion.
Thank you. And Dr. Han is asking if eye protection is as important as a mask over the nose and mouth.
I think eye protection is important for the same reasons that we talked about in terms of infecting mucous membranes. Mucous membranes, you know, can be infected, whether they're the nose, the mouth, the eyes. So certainly in the hospital setting, we're now all wearing eye protection when we see patients. They've been warned for a long time when doing any procedures that can create aerosols. And so I think while they may not be as important, I think they are important, particularly in certain settings, especially when you're dealing with patients that are infected.
And we have another question. Is there any evidence of long-term, how do you say that? Sequelae from systematic infection in children as reported in adults?
Well, we're hearing a lot of reports about people having sort of long-term problems, not feeling well, and having a variety of long-term symptoms and things that they're probably attributing to the infection. So I think we need to learn more about that, but there is some evidence that people are experiencing long-term sequelae.
And then Dr. Hardy, I had a question and I lost it on the screen. Asking about Great Barrington Declaration.
Great Barrington Declaration. Explain that, please.
Dr. Hardy, do you want to unmute and? He's getting unmuted so he can ask his question.
Okay.
There was one that came up. It said, what would you recommend to a parent, particularly a mother, who finds out she is infected to protect her children?
Well, I mean, you know, that's a tough one, because obviously a mother has to take care of her children. But I think, again, the wearing of masks and hand washing within the household setting is probably the most important thing that, or things that can be done. And then just paying attention to whether the child is beginning to display any symptoms and take them for medical care promptly to be tested. You may also want to test them right at the outset If you find family members who are positive, it's probably not a bad idea to check other members of the household at that time.
So I unmuted.
Go ahead, Dr. Hardy.
So the Great Barrington Declaration came out, I guess, about a week ago, which was against lockdowns and other economic restrictions, but instead focused on focused protection for vulnerable people like myself, and getting everybody else doing their work and going to school. So it's authored by epidemiologists, doctors, and economists. And there was an article in today's Wall Street Journal about it. So I think we're going to hear more and more about the Great Barrington Declaration.
One of the doctors in the audience.
One of the doctors is in the audience? Yeah. Yeah, I mean, you know, I would love to see things open up as well, but I think we have to do it in ways that are intelligent and careful. And I think we have to, because we're already seeing what's starting to happen as the weather is turning cooler and the fall is here, that the numbers are going up. And, you know, we hit the highest number that we've had yesterday. And I think those numbers are going to get higher. So we looked at the Spanish flu curve, and we can't predict the future, but if, I know we're in Las Vegas, if I had to bet, I'd bet that the fall and winter curve is going to be higher than the one that we saw in the spring. Now, whether people will get as sick, I don't know. I mean, I think we certainly know how to treat people better than we did in those early days, but I don't think we would want to see hundreds of thousands of new infections per day and have schools open and have all kinds of things just wide open and spread it even further. So we talked about flattening the curve back in the spring. What you're proposing is not going to flatten the curve, I don't think.
So I think one of the things that people talk about is the cases may not be the diseases. So the more we test, the more we're going to find. So what is the percent of cases versus the disease?
Well, you know, we've looked at data in our state. I mean, the percent positive rate has been hovering around 10% for a while now. That's a pretty high percentage. And so, you know, if you have 40,000 cases a day, 10%, that's 4,000. But if you have 150,000, well, you know, I mean, we can all do the math. I mean, as we do more testing, that's not the reason we're seeing more cases. We're seeing more cases because the percentage of positive tests is so high. And so we're just finding things that are there. You know, so it's.
Are we not having more cases that haven't been tested? Is it not true that we have more cases? Because, I mean, some of the ER docs say you've got it and they're not actually doing the test.
Well, how do they know? How are they saying you've got it without them having done the test?
For me, that's a problem.
I think that's a problem also because, you know, now, especially in this season where it could be RSV, it could be influenza, it could be adenovirus. I mean, you know, it could be something new that we haven't even detected. Yeah, I mean, I think the testing, you know, we need to have testing widely available, and it's certainly improved, but it's still not at a point where I think it should be. We were promised early on that anyone who needs a test will get a test. Well, that still really hasn't happened, and I think we need to get to that point.
So we're supposed to be taking a break, but I don't want to end this conversation. So certainly anyone needs to go take a break, stretch your legs. Our next speaker will start at 2:30. But Dr. Dijon, if you're willing to stay on, I do think we have a couple more people who want to ask some questions.
Absolutely willing.
Dr. Copes, I see you there. Did you want to ask a question? No? So we have, is it possible the spikes in cases graph you showed has to do with increased testing? Is it possible the virus has mutated, explaining the decrease in death rate?
Well, I mean, we're seeing more cases because I think there truly are more cases. There is more testing, yes, but I think that's probably in large part because people need to be tested. I mean, either they're getting sick or they're exposed to someone. As we do more testing and you find more people who are infected, obviously the mortality rate that has been described is going to, that's sort of a moving target, if you will. So the mortality rate, I think, will continue to fall as we test more people and know have a better denominator. So I think that's why we're seeing the mortality rate fall. But are people getting sick? Yeah, I mean, I think people are getting sick, and it's not just because we're doing more testing.
And Dr. Lampert, did you want to unmute and ask your question?
Yeah, I can ask it. So I heard it on NPR, but I heard that in some parts of the world, they're giving BCG because they think that any live vaccine kind of boosts the general immune response. They've seen that in children, so they're trying it with adults now. And my question isn't whether we should give BCG, but have we looked at the children who get more severe disease? Are they ones who either haven't been vaccinated with like MMR or varicella, or it's been a longer time since they last had a live vaccine?
Yeah, I mean, that's a great question. I don't know that we have the data to really answer that. I know people early on were looking at BCG, because it's widely used in many countries in the world. I mean, here we rarely use it. But it raises that question of, is there some sort of immunomodulating effect from that vaccine or from other vaccines that stimulate not only antibodies, but T-cell immunity, like measles, for example. So I think those are questions that need exploration. I don't really have a good answer for you at this time, though.
One question in the chat is how long you should wait to test someone who's asymptomatic, given that the incubation time is 2 to 14 days.
Someone who was exposed, you mean, but asymptomatic?
I'm guessing that's what they mean by the question, yes.
Yeah. I would, someone that was exposed, I would test them fairly quickly because you don't know if the person they were exposed to got it from someone else in their household or, so this is where contact tracing is important. But I would tend to want to test someone that was exposed early on to know their status. I would advocate for testing.
And then there's a comment question. If males are more susceptible than females, is the same true in children? And does blood type, does type O matter for susceptibility in children?
So in most of the studies where they gave data on gender, there was almost always a slight male predominance, even among the pediatric patients, probably somewhat more so among the adult patients. As far as the type O, I would think so, but I'm not sure the answer to that.
All right, and then is there a possibility of using remdesivir nasally, so prevention of exposed to someone if they're positive?
Possibility of using remdesivir how?
Nasally.
Nasally.
Hmm.
I have not heard of that. I only know its use parenterally.
Okay. And you'll have to forgive me because I'm not sure what PCR is. How long after infection will PCR testing be positive?
That's still an open question because it is such a sensitive test and it's picking up viral genome. And so oftentimes we've seen in people that have seemingly recovered from their symptoms and their illness and have effervesced that because there were these early recommendations needing 2 consecutive negative PCRs, and that turned out to be problematic because the test is probably picking up viral remnants, not intact virions that are infectious. How long that lasts is not really clear, but probably at least several days to weeks, but maybe even longer. So that's why they really moved away from requiring consecutive negative PCRs to say return someone to the workplace. And we're going more really based on time or symptom-based criteria.
Okay, and just one last question before we go into our next talk. Can you give the general pediatricians an approach to handle the sick kids this winter, especially kids with fever with no known exposure to COVID?
Well, I mean, I think, respiratory viral panels are excellent tools. I have heard that the SARS coronavirus 2 is being added to some RVPs. I don't know if that's come to pass yet, but certainly I would look for RSV, I'd look for influenza A and B, do coronavirus testing when indicated, other respiratory pathogens as well, and give your flu shots. That's my basic, and other vaccines as well, by the way. Yeah.
Yes, excellent. Excellent last point. I love it. Well, this is great. This has got the most chat of all of our talks so far today. So informative. There is a recording that I will make available to people afterwards. But Dr. DeJean, we're so lucky to have you here in Nevada. This was an excellent talk. Thank you very much.
You made it easy for me. You gave me a hot topic.
Okay, great. Thanks so much. I'll turn it back over to our chapter president, Dr. Greenspan.
Great. Well, thank you again, Dr. DeJean, and I'm sure there will be more questions coming up down the road, so we appreciate having you as a resource down here. So our next speaker is Dr. Natalie Muth, and Dr. Muth is a pediatrician and registered dietitian based in Carlsbad, California, where she is the founder and director of the